you, but I'm going to direct them over to our Facebook stuff.
Okay.
Cool. There's a little bit of a whistling in the background. I don't know if it's coming from you or me, but it's, that's the beauty of all this stuff. It's all good. So welcome. We're live with Dr. Jim Sumners from El Paso. Is that right?
That is correct.
And we're going to talk about cerclages and prematurity and recurrent pregnancy loss and the effects of all of this. For my Instagram people, we got Dr. Sumners. It's Sumners, correct? I want to make sure I have it correct.
You have it correct.
Some people say Kiltz and it's Kiltz, but either way, they can call me AQU anyway. But we're going to be talking about prematurity and repetitive losses and transabdominal cerclage. So why don't you sort of tell us a little bit about yourself and how you got down to El Paso?
Well, the recent move to El Paso was to join the department, Dr. Reddy at Texas Tech and the medical school here at the Paul Foster Medical School was encouraging to me that we could attack extreme prematurity, particularly, and second trimester pregnancy loss, and do it from several different viewpoints. The most visible, it seems, is the abdominal cerclage surgery that I do, where I see people from all over the country because they're frustrated with pregnancy loss. They're frustrated with having babies born at extreme early gestational ages and risking death and long-term damage. I'm no longer a handsome 24-year-old, and so I have to be satisfied with experience. And a lot of people don't mind talking to and working with someone who's been around for a few years.
I think there's value in that for all of us, and we've spent many years learning and honing our trade and understanding the things that we're really good at. And I know for me, generalized, and I've come focused on the reproductive immunology and things like that. And you are a board certified perinatologist, is that right? What's your background and training? Maybe tell us a little bit about that.
Well, a key part of my background and training was early in my career, where I became affiliated with St. Jude Children's Research Hospital, and I learned a great deal from the people there. One thing is how to take care of kids. I became a pediatric resident there, and I eventually did newborn intensive care and did that for some years. And then I realized that we really need to fix extreme prematurity from the obstetric side. Our colleagues in newborn intensive care, where I was, do a great job, but they're limited by their ability to work on kids who've been protected from extreme premature birth. And the pediatricians, the neonatologists can't do that. We have to step up from obstetrics. And what I learned at St. Jude was from a group of mentors there who recognized the need to step up to treatment of childhood cancer, which was, the treatment was unpopular back when they started, and they had to step away from the crowd. And that's what we're doing, is stepping away from the crowd to treat and prevent extreme prematurity and, secondly, second trimester loss.
And tell us a little bit about the who you're looking at that you think really needs these cerclages, and why do we? First of all, I guess the question is, why do we think that it's so common today? Do you think it's more common today than it has been in the past?
Not necessarily. Mm-hmm. I think it has been poorly recognized. We were fortunate in one thing we did that gives us a current observation that tells us that some people are different about presenting with early losses and extreme prematurity. I began in 2002 because of some experience I'd had and because of the frustration with extreme premature birth in triplets. And I began to offer them abdominal cerclage. By 2013, we published our data on that, which showed that the extreme prematurity, birth under 28 weeks, was reduced from 13% to 2% and now less than that by placement of a prophylactic abdominal cerclage. Now that's remarkable because it tells us that something is happening at the upper cervix. And more recently, now I've done and managed 131 patients with triplets who had abdominal cerclage placed prophylactically. And one of my colleagues who helps take care of patients in the hospital, he pointed out to me that these patients weren't coming in with preterm labor. Now, that's remarkable because it seems that all triplets back in the 90s at least presented with preterm labor. And that's what made them show up with very early deliveries. Now we're typically delivering triplets at maybe 32 weeks if they have preeclampsia, which precipitates it, but more commonly between 34 and 37 weeks. And they do quite well. And this is a distinct difference because the abdominal cerclage is placed above the ligaments that attach to the upper cervix. It's different than any vaginal cerclage. Vaginal cerclages, sometimes people claim they can place them really high. And I have to say that that's not really pertinent because you have to place them above the cardinal and uterosacral ligaments, which are the ligaments that attach to the upper cervix. And if you do that, then the failure rate with abdominal cerclage is well under 5%. The failure rate with vaginal cerclage is probably 10 to 30%. And the failure rate with medical treatments for people who already have cervical incompetence demonstrated by prior pregnancies, the medical treatments are not very successful at all. So I tend to advocate, at least if you think it's cervical incompetence, a weak cervix, utilize a very low risk procedure at the minimum, which is the vaginal cerclage. And some patients will do better and will be more successful with an abdominal cerclage approach. We demonstrated that the abdominal cerclage is not a dangerous procedure, which is a common misconception, and published that, I think 2011, something like that. And the first 300 I did during pregnancy. And now with over 1,000 patients we've operated on, we still find it's a very low risk procedure. The things that people worry about, the doctors worry about, is that it can produce a lot of bleeding during the surgery. I have been very fortunate that I've encountered need for transfusion rarely. Over 1,000 patients I've operated on, 5 patients required transfusion. That's a pretty low number.
So the risk of this procedure is pretty low. In general, what's the earliest you'll do these and what's the latest you'll do these for those that are pregnant? And is the preference when they're not pregnant?
Yeah, I prefer to do them somewhere between 12 and 14 weeks, and I'll cheat a little bit on the either side of that. On the early side, patients really want surgery done as early as possible. The difficulty with that is that naturally occurring losses are more frequent prior to 11 weeks. And what I mean by naturally occurring losses, these will be the babies where the baby itself has a problem that limits its survival. And these will be frequently chromosome abnormalities that limit survival. So I don't really want to have a woman undergo a surgery, which is becoming more popular, to do it at 8 weeks, but then you still have perhaps a 3 to 5% risk of a naturally occurring loss after the surgery, and women should not be subjected to that loss. Women, as you know, Rob, you know that women feel responsibility for everything negative that happens in a pregnancy.
Mm-hmm.
And I try to tell them every time I encounter them that they are not responsible for their cervix. They may have been in the wrong line when they were an embryo, when they got into a line to get a cervix and a uterus, and that's the only responsibility you could say. But we can't blame their mothers, because how do you decide which line you're getting into when you're pregnant to get a cervix or a uterus? That's
Which
silly.
is one of the biggest problems. We don't really know who is at greatest risk, and our ability to define them and diagnose them is poor. I mean, my sense is it's still some inflammatory process that is caused by the wrong diet. That's where I always go to, and yet why some people get it and other people don't. That's the mystery to all of this.
Well, I have some things. I'm not necessarily on your boat on the inflammatory process and so forth, but there's some things that we've run across. A guy named Professor Andrew Shannon tabulated some things. He's in London, and he tabulated some things that are associated with manifestation of cervical incompetence, which I think is the largest cause of both extreme prematurity and second trimester loss. And he tabulated that, first of all, a patient who undergoes a cesarean in their first pregnancy because of an obstructed labor, basically they can't push the baby through, they undergo a cesarean, they have a higher instance of manifestation cervical weakness in a subsequent pregnancy. The other things are that every patient who is pregnant needs to have a careful look at their cervix with at least a vaginal speculum exam to make sure there is not obvious damage to the cervix. And this could be from a prior delivery where there's a laceration up and down the cervix all the way to the end of it, or they have other damage because of shortening of the exocervix and maybe even the middle part of the cervix due to procedures done on their cervix to interrupt the precancerous process. The third thing that we ran across, I think it's the third thing, or maybe I've lost count, but the other thing we ran across just serendipitously is that I thought the cervix was small in some patients. And so we did a study where we looked at a group of patients who were totally normal in their subsequent pregnancy, and another group of patients who came to me with what I call congenital cervical incompetence. In other words, they didn't have any previous procedures, they didn't have anything damage to their cervix from extraneous means, and they didn't have other abnormalities of their uterus. And we looked at the front to back diameter of the upper cervix. We found that those who manifested congenital cervical incompetence had a distinctly smaller front to back, anterior-posterior diameter of the upper cervix. We need to follow that up. That's going to require another look, and maybe I have to partner up with some people in reproductive endocrinology and infertility to get that done, to get a wider, larger group looked at. But that needs to be looked at.
There's so many questions here, and I know there's a lot of people suffering out there. We're going to take a few questions, and again, for those that are joining us today, it's Dr. James Sumners, El Paso, an expert on cerclages, transabdominal. Been doing them for years. Amazing expertise. We're on both YouTube and Facebook primarily. See My Fertility, and then also our Instagram. Come on over to Facebook, YouTube. But Audrey has a comment questions that, if I may, she lost twin girls at 24 weeks last month. How do I know if it was preterm labor or incompetent cervix? Only felt contractions for about an hour, 15 minutes apart before going to labor delivery. Was dilated 5 centimeters with bulging bag. Held off for 2 days at the hospital before dilating completely. 36 years young, leaped 10 years ago, 4 rounds of IVF to get pregnant, did not have a transvaginal. And the question is, would a transabdominal cerclage, or maybe you could comment about that. Thank you, Audrey White, for your question.
Well, Audrey, I'm sorry that happened to you, and you did not participate in that loss. You were a victim, and your children were victims of that loss. But you didn't cause it. I see a lot of patients in this circumstance, and some of them are told, well, that was probably because of the twins. Let's just see what happens in the next pregnancy. Well, that only happens in that sort of thing with extreme prematurity or second trimester loss only occurs at somewhere between 4 and maybe 8 or 10% of twins. So it's a minority of twins. Twins did not cause that, okay? But the cervix being weak will cause it. And the twinning exacerbates it somewhat, but it'll still happen. So I see a lot of people in that circumstance, and I think that they need to have a clear view that their big risk is the cervical incompetence and any subsequent pregnancy, and that they have a choice of maneuvers. Progesterone has been utilized in the last 20 or 30 years, and I think that that's a reasonable thing to do. I suggest that vaginal progesterone treatment from 16 to 34 weeks is a reasonable thing to do, but I don't think that's going to fix cervical incompetence. The choice then is 2 surgical procedures. The surgical procedure that is more common is the vaginal cerclage, which basically holds the cervix closed from about halfway up the cervix, but usually the upper cervix will dilate down to the cerclage, and they are at risk of failure of that cerclage. And the risk is probably somewhere 10 to 30% with a prophylactic vaginal cerclage done somewhere in the 11 to 15 week range. So you have that sort of loss. It's a very low risk surgical procedure if it's done prophylactically. And that's why I say, if you think about it and you're not sure about the cause or whatever, at least that is an approach. The second approach is the abdominal cerclage, which has a failure rate under 5% for the pregnancy after 12 weeks. And the risk associated with that procedure is what I was talking about. Well, a less than 1% risk of bleeding requiring a transfusion, wound infections, damage to internal organs, and done during pregnancy, we established that the risk of loss of the fetus because or associated with the procedure is about 2%. Okay? Now, when you're making medical decisions, you not only look at the procedures available, the risks of the procedures, but the value of the outcome. Now, that's where, unfortunately, a lot of doctors, it seems, are not on the same page with the patient for the value of the outcome. I've heard so many patients say, my doctor told me, well, we'll see what happens, or we'll do a vaginal cerclage in this circumstance. And particularly if they've had a failed vaginal cerclage before, and we'll see how it happens. And if you have another loss, we will consider the abdominal cerclage. Patients are not really on board with that assessment of the value of a baby. Okay? If you lose another baby, then we'll do something that's more serious. I find that patients are not really happy with doing anything less than the most serious approach.
So our medical profession and just maybe society in general isn't really putting the appropriate value to fertility and childbearing, and it's sort of, well, just you try again and you'll be fine, which is kind of
Right.
very inappropriate and unacceptable, I think. And I hear too many doctors, I think, we're not taking it seriously enough. And as you talk about the emotions and the personal nature and feeling in some way that it's the person's fault for it happening, when in reality there's something that is greater, and science has learned so much, and the techniques that you've learned over the years have been quite valuable in all of this. And so, how do we change the current approach and mindset of us in the medical profession?
I need help with that. Okay, they will eventually listen to data, but they're quite slow about it, and I think it has to do with the view that if you lose a baby, you can get pregnant again, and that's something, as you know, you never tell a woman who has lost a baby, whether it's first trimester, later on, whatever. You don't say to them, oh, you can get pregnant again. That's terrible.
Fertility is still, when it comes to coverage for insurance, and there's Kylie. I'll bring this up because I think it's appropriate for your conversation. Transvaginal cerclage emergent, MFM dilating through it. 10 days, OB went in and put a second cerclage in it. She did make it a full term. Insurance refused to pay for it. Right? Pay for a TAC, so I'm on to a transvaginal cerclage again. This is our society, our community, and how we approach this, right?
Yes, and we do interactions with insurance companies to point things out to them. We point out the low risk of the abdominal cerclage procedure and the tragedy for also the insurance company if the woman has a baby at 24, 25, 26 weeks, and the NICU cost is typically somewhere between, for a surviving baby, is somewhere between $500,000 and about $2.5 million. Plus the long-term effects. Many of the babies are, as their parents see them, as I see my children, are perfect, but they have some things to contend with. Mm-hmm. And they may have blindness. I've had a patient tell me, oh, he was born at 26 weeks and he's 10 years old now and he makes straight A's at the blind school. Well, I think that child should not have to endure blindness. We should work against that. And so the long-term efforts, because including pulmonary care, which is typical that they have to have lung care for up to 5 years. They have tracheostomies that have require care and eventually get removed, but they'll be typically maybe 3 or 4 years with a tracheostomy in place to allow them to breathe. They have sometimes worse things than that. I know a young woman who was talking about her care of children and young adults with physical disabilities from cerebral palsy. And she helps them to resolve those things, to live with those things. The issue of the insurance coverage, we have to help with that some of the time. And we try to do what's called peer-to-peer discussions with physicians designated by the insurance company that point out some of these things. And the typical cost for an abdominal cerclage placement is very small compared to the even a couple of days of newborn intensive care.
So let's see, a couple of comments on our Instagram. A Camp B1, if you have a history of incompetent cervix, are you destined to have incompetent cervix with all subsequent pregnancies?
In general, yes.
So
you would have to have something that completely cures it.
And the cerclage, the tack would essentially do that. And that's the only thing we know at this point, right?
Right, because it's placed at the top of the cervix, above the ligaments, and it's not going to get pushed down. Are there some risks with the abdominal cerclage? Yeah. Are there some downside failures? Yes. They're very unlikely.
How long does the procedure take when you're doing a tack? Are you doing it robotically, or are you doing it? How are you doing that transabdominal cerclage?
Well, I did a safety trial of doing it during pregnancy, and I published that. And I was, and I still remain very questioning about placing the abdominal cerclage during pregnancy with a laparoscopic approach. There are a number of people doing it. I think you have the risks of the operating on somebody at 8 weeks, which many people will do with a laparoscope, but also you're trying to operate, as I say it, on the other end of a water balloon. And you can't do that technically very well. So I suggest that doing the abdominal cerclage with laparoscopy, which I do a lot of, I've done over 300 now, and it's a very common request that I do it when they're not pregnant. And it's a very straightforward procedure when they're not pregnant. It is an outpatient surgery, except in somewhat unusual circumstances. So they don't even stay overnight in the hospital. And they, of course, have some discomforts and some post-operative pain, etc. But they recover from that quickly, and they're very happy that they can expect a good outcome in a subsequent pregnancy. The other patients, I suggest doing the patients who are pregnant, doing them by laparotomy, an incision on the abdomen similar to a cesarean incision. And that allows me to get behind the uterus in most of the cases, and to do a very proper operation that fortunately is a relatively short procedure. We're usually talking about somewhere between operating room time, between an hour and 2 hours, and for either procedure. And it's straightforward for me.
Are you seeing patients from all over the country, all over the world? What are your patients and how do they find you?
Well, they find me online. I think some of the people who are watching and listening here have run across my name because there used to be 3 of us in the country and in the world that were doing the lion's share of this operation, and the other 2 have retired. And I'm resistant to retirement, and my wife would not appreciate me staying home full time, I don't think, as much as she appreciates me otherwise.
Mhm.
And I think that's a common event amongst many men who are considering retirement. And so my volume of abdominal cerclage placements went up when Dr. Davis retired from east of Philadelphia, and Dr. Haney retired last year.
Are we training new physicians in this procedure?
What we want to do here, and that's the support of the department here that has brought me to El Paso, is that we will have a program to prevent extreme prematurity and second trimester loss. And part of that program will be clinical research, and part of that program will be training other physicians to not only do the surgery, but to deal with the issues surrounding cervical incompetence and advance that work.
So we are making a move to try to do this more and more. And, that's one of the things that I think is really critical and important, that we're training new people to do it, creating the center like you're doing it, and encouraging the conversation. And I know that I've seen that most of what we're doing is we're learning from our patients who are pushing for these things. They're going out there and finding the resources themselves. And I say the knowledge of medicine is on the internet today. When we were in medical school, you had to go to the library. You were accepted. You had to qualify to get a permit to go into there to get the knowledge. But now it's free and easy to find, and our patients are talking about it. So I think that's really important, that we're inspiring more and more people to do it. But Noel Lilo talks about, thank you. They traveled from Seattle to Indianapolis. And again, that let's see, how is incompetent cervix diagnosed? I have a history of premature labor, but no one has looked into why. And you mentioned abdominal or vaginal ultrasound. Should we be doing those on all of our fertility clients? Because so many of them get pregnant and then they lose their pregnancy early on. It's hard to know. There's probably something more going on that's related to reproductive immunology. But then how does reproductive immunology fall in place when it comes to an incompetent cervix? Any thoughts
Yeah.
on that?
Well, hello, Noel. How are you? I hope you're doing well. Yes, the key to looking at the cervix is to do vaginal ultrasound. Since around the late 1980s, we've had vaginal ultrasound, which allows us to use a higher frequency transducer, which gives us more well-defined pictures of the cervix, as well as the ovaries and the uterus and so forth, in the non-pregnant patient. And that's the way we should monitor patients during pregnancy. And I think that all patients should have at least an 18 or 20 week ultrasound, a vaginal ultrasound of their cervix, and that patients who have any history of manipulation of their cervix, procedures on their cervix, prior cesarean after obstructed labor, and people in general should be very carefully looked at, and some of those looked at multiple times between 16 and 24 weeks. And you'll get an idea of what's happening at the upper cervix with the vaginal ultrasound. And if you see that, then you can try to act on it as early as possible to interrupt the loss that is ongoing.
So the patients may feel nothing. And Tracy Dopp, thoughts on she's 23 weeks, twins. The cervix is 0.9 millimeters, and they're watching her pregnancy. She's on bed rest and progesterone. Any thoughts on that type of story?
Well, one of the things we don't completely know is how to treat this most effectively. I certainly can agree with the progesterone. The bed rest may or may not help. Where do you stop utilizing at what gestation do you stop utilizing a rescue or an ultrasound indicated vaginal cerclage? Even where do you stop with placement of an abdominal cerclage? Although I really am worried about those. It's a much more risky procedure when the cervix has opened at the top. So I don't have a good answer for that. I certainly hope she gets much further in pregnancy, and her first goal should be 28 weeks, because that's where you get your largest increment in improvement in survival and survival without impairment. Looking at you had asked before about where are these people coming from, and though I have a few from Canada, and I've had a patient from Venezuela and Egypt. Before I came down to Texas about a month ago, my patients, over 70% of my patients were coming from outside Indiana. And so it's a request from all over, and it has to do with people looking for someone with experience. It's the same thing you would do, Rob, if you were faced with some operation that's not a really common operation. You'd find out who does a lot of them and
What's your
talk
thought
to them beforehand, which is something I do.
Let's see, Zara Ambros. I had a failed cerclage 4 months ago, 22 weeks. And then Kelly had a leap years ago. Should she have a TAC? So obviously, it didn't say if it was a vaginal or abdominal cerclage in that failure. But if someone just has a history of a leap, is that enough for that cerclage to be placed before she's pregnant?
Well, if she had a failed vaginal cerclage, then that's an indication that most everybody in maternal fetal medicine and generally in OBGYN will accept as a reason to do an abdominal cerclage. I've had a few encounters indirectly, most times, with physicians in maternal fetal medicine who will have a failed vaginal cerclage and then place another vaginal cerclage in the next pregnancy. I would suggest that that's not a good idea, if I can say that as mildly as possible. They say insanity is doing the same thing over and over again and expecting a different result. No, if you've had a failed vaginal cerclage and have a diagnosis of cervical incompetence, have a failed vaginal cerclage, the next step is an abdominal cerclage. And placed prior to pregnancy is a great thing. It's easier to do in the somewhat heavier patient. It's an easier operation to do it with a scope prior to pregnancy than to do it during pregnancy with an incision on the abdomen.
So many people spend so much time and money, and fertility care is very expensive. And once they're pregnant, obviously, I'm sure many people will be looking at this and wondering, is this something I should get prophylactically once I'm pregnant? Or before pregnancy, because of my history of a LEAP procedure. I finally have that pregnancy from IVF after 5 years and $100,000, and I've had a LEAP. Could you do that procedure?
Yeah, and I don't know the patient who has no pregnancy history, and this is their first pregnancy or they're anticipating their first pregnancy, and who has had a procedure on the cervix, some of those should have abdominal cerclages. And those typically are people who've had fairly aggressive procedures on their lower cervix, where the residual cervix may be only a few millimeters or maybe a centimeter and a half or something like that. And those, considering the risks and the uncertainties and the fact that you can't fix it if the cervix starts opening up, if there's no lower cervix, they will do better with a prophylactic abdominal cerclage. Now, other thing is the abdominal cerclage is not perfect. So what do you do if there's a failure? Generally, there are two things that people listening here should know. First is, after they've had a successful pregnancy with an abdominal cerclage in place, they need to have their cervix and the cerclage looked at before they achieve another pregnancy. Because sometimes a successful pregnancy delivered at something like 39 weeks with an abdominal cerclage, delivered by cesarean, that the late pregnancy and the weight of that late pregnancy, the force on the cervix, it will tear through one side of the cervix. We need to know that before they achieve another pregnancy. The second thing is watching the cervix with vaginal ultrasound during a pregnancy with an abdominal cerclage in place. Sometimes you will see a rare event where the upper cervical canal opens up inside the cerclage, even though the cerclage remains sufficient. It's holding the cervix not completely closed because the canal opens up, probably because the wall of the cervix thins out. Okay, that's a bad cervix that unfortunately you're working with. And so what we found, and a guy named George Davis taught me this, he was practicing in east of Philadelphia when he did, is to, in those circumstances, place a vaginal cerclage. And that can be maybe miraculous. The most recent one we had was a patient with an abdominal cerclage placed because she had triplets on board, trichorionic triplets, 3 placentas. And I placed an abdominal cerclage at 12 or 13 weeks. She, at 17 weeks, we looked at her cervix and the canal had opened up at the top and was looking like it was going to go all the way down to the end of the cervix, which I had seen before, and George told me about this. I placed a vaginal cerclage, and this patient with triplets on board delivered at 36 and a half weeks. The only trial that she sort of went through was the fact that the triplets went home with her when she was discharged, which represents a prodigious effort on her part and her husband's part.
Oh boy. So let's see. After attack, when is it safe to get pregnant? So I'm assuming if it was a prophylactic, not pregnant, how long after that do you encourage natural pregnancy or IUI or transfer?
Well, in terms of the patients that are seeing doctors like you who are trying to achieve pregnancy through assisted technology, then I ask them to check with you, because that's a complex issue of when they ovulate, what part of the cycle you want to do a transfer, things like that. Otherwise, I ask them to please not try to achieve pregnancy in the parking lot of the hospital before they leave.
So they don't have to wait, essentially.
Right.
It's there. It's a barrier that's going to help them from the moment that it's put in there. Does insurance in general cover this? And if they're coming from out of state, is that a different process? But In general, have you found that insurance companies usually will pay for this procedure?
One way or another, we usually have insurance paying for it. They may hassle, argue, require peer-to-peer, etc. I'm not an expert in addressing insurance companies, and I don't know anyone who is. But I think that the patients, it's important as we go along to play the newborn intensive care cost card with insurance, because they will save money. I mean, you don't have to have very many $2 to $3 million newborn intensive care bills and avert those without saying, gosh, it's probably a good idea to do this.
And you haven't had the need to, when you're talking the peer-to-peer, I'm assuming many of those docs will go like, yeah, you're right. That makes sense. We're going to make this happen.
Yeah, very few are denied after appeal.
Yeah.
And looking at costs, let's multiply that out. The usual delivery of a patient with trichorionic triplets that we talked about, that would be 3 times if they had a 25, 26 weeker. That'd be 3 times the cost. So you're talking about $6, $7, $8 million NICU costs, plus any long-term care costs. I mean, you can pay for a lot of abdominal cerclages.
Oh yeah, wow.
With that sort of money.
Of course. Let's see, Vanessa Lynn. I've had a doctor say because I had cramping the day before I delivered my son at 21.6, they wouldn't say it was incompetent cervix. Can you have pain with incompetent cervix? My placenta was found to have an infection afterwards, which it's always hard to know which thing came first. And maybe you could talk a little bit about that. Could the dilation happen, then the infection, or vice versa? What's your thoughts on that? And
I have a firm opinion on that. One of the things that we noticed right off with the first publication about abdominal cerclage prophylactically in triplets was that they didn't rupture membranes. Very, very rarely prior to birth. Now, the rupture of membranes occurs because of colonization of the membranes through loss of the cervical mucus of the cervix, the mucus of the cervix, which protects against the bacteria from the vagina climbing up to the membranes. And so that's the reason they don't rupture membranes. And rupture membranes or colonization of the membranes with bacteria from the vagina is what generates infection. Now, if you look at a pathology study of placentas from, say, 18, 20, 22-week deliveries, they almost all have evidence of infection. Well, that doesn't surprise me because their cervix has opened up, their cervical mucus has gone, the membranes are colonized, so of course you have what's called chorioamnionitis or placental infection. It's a secondary event.
Do you commonly treat with antibiotics pre-post cerclage?
I give prophylactic antibiotics before either vaginal or abdominal cerclage. So these will be in the preoperative area. They will get a dose of intravenous antibiotics. That's commonly done, as you know, in obstetrics and gynecology for a variety of operations, including cesareans. And it seems a logical thing to do. I don't have any proof that makes a difference one way or another.
Lucy Clemens asks about private pay costs. If she has no insurance coverage, they won't cover it. Does your hospital or program provide a self-pay discounted rate for any reason? Do you know?
Yes, the hospitals will give a discounted self-pay rate. We are working with the hospital administration here, because I've only been here a short period of time, to get to exactly what that comes down to. In Indiana, we had a specific cash pay rate.
And when you're doing these abdominal cerclages, do you ever note endometriosis? And you guys ever treat it? Kelly D asked about whether or not you're able to treat it at the same time. And my question is, are you noticing more endo or in these cases at all?
I don't know that it's more. As you know, many people undergo laparoscopy to diagnose endometriosis and to treat endometriosis that's known, to alleviate symptoms. And when I see endometrial implants, I often will treat those with electrocautery during the process.
So if you see it, you treat it while you're there, but not necessarily seeing it anymore. Let's see. We'll get tacked on. We decided to give. So we kind of answered most of those. Do you have any other thoughts and ideas that you wanted to share with our viewers today on how about incompetent cervix, cerclage, extreme prematurity, ways that we can approach that, and things that they may be able to do to help their practitioner understand what they're going through and direct them into some treatments?
I think education is very important. Education of the physicians is very important. The patients are already educating themselves, and they usually have more information than the physicians they're seeing, just because it's not a common thing for them, many of them, to even talk about cerclage efficiency and transabdominal cerclage. But I think what I do with each patient within the day or a couple of days after I operate on them, I call their physicians, their OBGYNs, their maternal fetal medicine, and their REI, infertility doctors, and talk to them about what I do, pitfalls, make sure they have the contact information. If they run across something that goes on with the pregnancy, they can call me, and we'll design a treatment that individualizes to that patient. And I think that's the level of education we're working with right now. Other things that we can do have to do with publications, and so far I've found that not as many people who are reviewing journal articles for publication in the United States are on the same page with me compared to, say, the people in London.
Mm-hmm.
But we've got to keep going at that.
Yeah, we can't stop educating and learning new and different things in this process. And the social media, which is crowd-based knowledge, and these opportunities to talk to people with your caliber of expertise and knowledge is very important. And I'm thankful to all those that have joined us today, and bringing more and more to everyone. So I'm going to say thank you, Dr. Sumners, for this conversation today. You and I can stay on a couple more moments longer, talk about some future ideas. Maybe we can get you and your team to provide an article about incompetent cervix and the benefits of cerclage in our new family building guide, which then will give people some knowledge and resources for them with your expertise. So,
well, I'm also, Rob, I'm reminded that I actually have an informational Facebook page. It's not for friends. It's to give information, and it's called cerclage, cervical insufficiency, and transabdominal cerclage. And also many of the patients that have come on and asked questions have availed them of the information that is often helpful on the what's called Abby Looper's Facebook page. Thank you.
So there's so many resources out there, and we're grateful to everyone for joining us today. And I'll see you guys next week. And again, the 10 o'clock Facebook, Instagram, YouTube Live on the Fertile Conversations, and then a guest at 11 o'clock Eastern Time to bring some other ideas and things. So again, thank you. And sorry for my Instagram team, but we'll get some things there for them. And I'm going to end the broadcast. And again,